Okay, Anusha, the floor
Yes.
is yours. So, briefly, let us just introduce this. What we do is every month on the last Friday at the same time, uh, we have a calendar event where we discuss a patient of vertigo and have a discussion around that so that we can look at uh, things which we have missed, options which we should consider in future, and hope that in this discussion we learn small points. We are not talking down to anybody. We are not trying to pretend that we are all experts. I think we all have to let our guard down and admit that vertigo is not such a simple topic. Every patient is individual, every patient is different. Many manifestations are protean. Many patients, if you follow them up, their diagnosis tend to change. There is coexistence of various diseases in vertigo, and that is known. So today's case would be presented by Anusha. Anusha is a dedicated neurotology doctor, trained and working in Bangalore. And we are honored to have Dr. Rajiv. Dr. Rajiv was a former head of Department of Medical College and now uh, runs a clinic and is attached to one of the premier hospitals also in Bangalore. Rajiv is a person we respect. He is very methodical, very academic, and very knowledgeable. And so I hope between the two of them, with occasional interjections from me, all of us will have leave this meeting with some slightly better knowledge of practice of this particular condition. So, Anusha, the floor is yours.
Thank you, sir. So, hello everyone. Today's topic is vertigo and pregnancy. So, before going into actual case details, I want to talk in general about giddiness or vertigo in pregnancy. So, in pregnancy, there will be a lot of physiological changes in hormones and also in metabolism. So, generally, we'll be having physiological nausea and vomiting in pregnancy, and orthostatic hypotension, and also anemia, etc. All these conditions can give rise to giddiness, making it a very common symptom among pregnant women. Apart from these physiological changes, there are some actual vestibular disorders with increased incidence in particular in pregnancy. So, the examples are, if we see Meniere's disease, so the increase in frequency can be explained by two factors like reduced serum osmolality during pregnancy, and also there are some receptors, estrogen-based receptors on the endolymph sac. So these receptors will activate aquaporin channel activity, and this can give rise to more water permeable, more water movement into the endolymphatic sac and endolymph. So this can give rise to more increased frequency of Meniere's disease. In some women, the Meniere's disease first episode can start in pregnancy as well. So, another most common vestibular disorder during pregnancy is vestibular migraine. So, this we all know that it is mostly interlinked with the estrogen and progesterone levels, as it is very common in females, and also it is more common during the menstruation time or pre-menstruation time. So, it is related to estrogen and progesterone hormones. So, this is expected that vestibular migraine will increase in pregnancy as well due to there is increased in female hormones in the blood during that time. And also there is more incidence of BPPV, in particularly like posterior, left side posterior canal involvement is more according to some studies that can be explained due to prolonged left lateral side resting position in like in during pregnancy, and like vitamin D and calcium metabolism changes can lead to BPPV. So that can be there will be some vitamin D and calcium metabolism changes in pregnancy as well. So these can explain the BPPV occurrence, more occurrence in the pregnancy. So as there is like incidence of these, so we have to consider them also. So giddiness in pregnant women should not be considered as physiological without proper evaluation. So that is my input. So now we'll go into the actual
So,
case.
no, so just, I think I just hold for a minute, and Dr. Rajiv, would you like to come in on this and talk about giddiness and pregnancy? Is there a functional element in giddiness in pregnancy?
Functional element can be there, sir. I had a lady who had severe vertigo immediately after the childbirth, and they go for postpartum. There are entities, I mean, conditions like postpartum depression and others, which the patient may express it as vertigo, but it turns out to be something else. Many of them have under enormous stress during the pregnancy, especially if it's a precious child or if they have some pre-existing comorbidities. And all these contribute to the symptoms. Maybe vestibular diseases, Meniere's disease, vestibular migraine, and BPPV are common, but there are other conditions also.
So just a condition that, nowadays with late pregnancies, which seems to be the practice, and a lot of people reaching out for assistance during pregnancy. There's a lot of hormone usage, there's a lot of medication which is given. And I think that is an unexplored segment as to the linkage between that and symptoms of vertigo.
Possible, sir. I have not come across such patients, but it is possible.
Because a lot of patients now it's considered almost passe. Like, I mean, if you really go into the history of whether this pregnancy is a natural pregnancy or an assisted pregnancy, you will find that the percentage of ladies who are pregnant now who have taken assistance is much higher.
But one thing which happens with assisted pregnancy is that the health is optimized by the physician before conception. So that might lead to a lower frequency of illnesses during pregnancy.
No, because many of them have been taking a lot, the stress which you mentioned about, no, many of
Sure.
them had many attempts to get pregnant.
Yes,
So
yes.
the stress element is really high in those patients.
Yes, sir, that's true.
But good. Go on, Anusha.
Okay, sir. So now going into our actual case details. So we are having a 33 years old female who is a housewife and also primi gravida. She has presented at 30 weeks gestation. So she is complaining of multiple spontaneous spinning sensations with vomiting, which is associated with oral symptoms as well. That is oral fullness, tinnitus in the right ear, lasting for all these symptoms are lasting for about half an hour to 1 day. So there are multiple episodes which is started from 5 years back. Before pregnancy, there are a couple, like 2 or 3 episodes only. But after getting pregnant, there is increased frequency of them. And at present, it is once in every week. So more in the second and third trimesters. And she's mentioning about positional vertigo as well. That means exacerbations are there while lying down and getting up. So, and along with that, hearing loss in right ear, she is mentioning, which is increasing gradually. And recent times, there is occasional tinnitus in left ear as well. So, this is the history of case. And moving into workup, like vitals are stable. So, we have moved on to video nystagmography. So, VNG findings during the episode, actually, VNG is not preferred as patient will be in more distress, and VNG is itself is a provoking test. So generally it is not preferred. Depending on history only, we should just give the symptomatic relief to the patient. Then we have to ask them to come for review to do the VNG. But especially she is mentioning about positional vertigo. So to rule out BPPV, VNG was done. So oculomotor tests are normal. Saccard's pursuit and optokinetic nystagmus was all normal. And during the episode, there is a mild right beating spontaneous nystagmus in dark. Without fixation, there is a mild right beating nystagmus. And after head shake, there is same with little bit increased in uh, intensity. There is right beating nystagmus. Positional tests were normal actually. There is no typical positional nystagmus. And after 10 days of after 10 days of this episode, after the VNG was repeated, which was normal, almost apparently it is normal. There is no spontaneous nystagmus, and there is no nystagmus after head shake also, and positional tests are normal. But caloric test shows some reduced responses from the right side canal. So the right side canal paresis is there. And Puriton audiogram, if you see, there is right side, um, to say it is mixed hearing loss with both bone conduction, decrease in bone conduction, and also there is low frequency AB gap, low frequency AB gap. So we have to follow these audiograms closely. After that, after this also, we have to review with audiogram to rule out any other chances of mixed hearing loss conditions. So, but in Meniere's disease, actually, this low frequency AB gap is common. If we see previous studies, so it is shown as common. So there is mixed hearing loss along with bone conduction and air conduction, both are decreased in right ear. So with this,
Can you just go back to the VNG and
yes.
what, would you like to give your analysis of this VNG?
Yes, sir, yes, sir. So in if like this is already, I'm saying it as mean years. So in mean years, the general VNG findings will be like sometimes it is ipsilateral nystagmus can be there, spontaneous. That is irritative nystagmus. That means that side the function is more. That irritative lesion is there, and sometimes after so many episodes, that side can go into hypofunction. So sometimes it can be contralateral beating nystagmus as well. So both can be possible. So here we can see during the episode it is mild right beating. So we can say it as maybe right side irritative lesion or left side hypofunction lesion. So that can be said during the episode. So after 10 days after episode, there is apparently normal. There is no nystagmus. So that might be irritative lesion and all. But
But you
caloric
had
test,
but you had canal
caloric test
paralysis
shows.
and
Yes.
audiometry tests.
Yes, sir, yes, sir. So, caloric test, it is showing a little bit hypofunction like canal paresis. But yeah, maybe I'm thinking that after so many episodes, it is going into this is early hypofunction. It is going into hypofunction in the right side. I'm thinking in those ways, sir.
So let me just stop here and just induce a discussion.
Mm.
So, Dr. Rajiv, could you tell us about, see, the first point she mentioned that we don't need to do a VNG during an acute attack. What is your opinion on that?
Absolutely, sir. If the clinical features are straightforward, we don't need a VNG. If we need to document the findings, perhaps we can just do use the VNG just for recording in the mode where you have just to record the eye movements. Otherwise, we can even use an external camera for documentation purpose. Um, why put the patient through more stress than they're already in? I would also strongly avoid the caloric test, especially in the third trimester.
Mhm.
You don't want to provoke a delivery on your
Yes.
VNG
Yes, sir.
patient. Okay, so there is a question from Dr. Manjiri. She is saying that is it possible that you are dealing with an autosclerosis?
Yes, yes, sir. Actually, there is, if we see clearly, 2000 Hz, there is a dip in SNH, like bone conduction. So
But the
there can
classic
be a possibility.
autosclerosis would have a dip and the rest of the
Rest,
nerve not be
conductive
like that.
hearing loss.
This
Yes.
low frequency dip is more in favor of Meniere's, right? Would you agree?
Yes, sir. Yes, sir. So there is no like throughout conductive hearing loss, only lower frequencies there is AB gap. So mainly we have to follow up this patient afterwards also. Then only we can say that definitely this is Meniere's or is there any
Yeah,
autosclerosis?
but I suppose she has a point in the sense that a lot of patients of autosclerosis, the autosclerosis manifests during pregnancy.
Yes, sir.
I think we have seen that a lot of patients complain that their hearing loss started with pregnancy. Do you agree, Rajiv?
Yes, sir. Many patients do present with worsening during pregnancy. It's quite a common feature in otosclerosis. With
Yeah,
this audiogram, I have another suspicion because I've seen similar problems in my previous institution where the bone conduction probe was not working well and the patient was responding to the vibrations, especially it's more in the lower frequencies. So that is also one possible issue which might be there in this audiogram.
correct.
Mm.
There was a comment regarding, uh, I think I missed that again. There was a comment in the chat box about in Minia's. Dinya,
There
would
will
you like
be
to say
only
something? Dinya from Iraq?
there will be only SNHL, not mixed hearing loss, conductive or not mixed hearing loss.
Dinya, would you
Yes.
like to say something? Please unmute and say a few words.
Hi there, how are you?
Hi, salam alaikum. Tell us
Alaikum salam.
what is
Okay.
your.
Well, I think I have seen too many cases of penile disease, but I haven't seen any of them with mixed hearing loss or conductive hearing loss. There is low frequency sensory hearing loss, or
Okay,
sometimes flat configuration of the pure tone audiometry, but
okay,
there's no conductive, I think. Am I right or
okay. No, I
Yes,
mean,
yes.
that is why Anusha said that this patient will have to be followed up. Even
okay?
we were a little surprised by the mixed element, but the fact that the bone conduction was showing a lower frequency dip was, I think, what made us feel. What do you say,
Sometimes
Anusha? Yeah.
Excuse me, sir. Sometimes this feature could be seen in superior semicircular dehiscence, where there is a large airborne gap, especially in the low frequency region, and you have pseudo sensory hearing loss. You have sensory hearing loss. You have bone conductions which are better than normal, but still air conductions because there's a third window. I think this picture is mostly seen in superior semicircular dehiscence and usually happens during prolonged labor and after a car accident there will be increased intracranial and increased intra-abdominal pressure which will make the dehiscence to open and make such a feature, but this is my opinion. I don't know
So this was
what's
in
your
the
opinion.
third trimester. It was not during delivery, but it's a good point. Rajiv,
Yeah.
would you like to comment on that? I won't claim that I have experience in seeing
Yes,
superior
sir.
semicircular canal itself, much less in pregnancy.
I have a vague recollection of conductive hearing loss being present when there is a high drops. I'm just looking it up, sir.
Yes, sir. There are studies I have seen also. Like there will be low frequency conductive hearing loss as well with along with SNHL due to vibration changes in the stapes foot plate.
So, Alida wants to know whether we did acoustic reflex because that might tell us something about the.
Yes, sir. Yes, sir. So, but yeah, we have to take it as collectively both the history and the findings. So, yeah, depending on that, we can say mostly Menias, sir, because it is along with what spontaneous episodes of vertigo and also tinnitus.
Fair enough. So I think you can move on now. But good points have come up, and we
Yes,
encourage discussion. I think that's a good
yes, yes.
way of going. Go
And
ahead.
yes, I forgot to tell this like before some months, the patient had another PTA, but I don't have that report. This thing that was almost normal, mostly very mild SNHL in the right ear, which is almost normal. We can so just to mention it and just know it before some months, maybe 5 to 6 months,
So
he
this was a
had one
sudden,
more PTA.
so this is a sudden drop, you mean?
Yes, sir. So fluctuations in the hearing loss is typical of mean years. So yeah, yes, sir. That point I wanted to add. Yes.
Go on.
Well, a document from Barani Society, sir. Can I share it on the chat?
You can tell
Basically,
us. You can
there
tell us
can
and
be a
share.
conductive loss because of a third window effect in endolymphatic hydrops.
Okay, like what? was told to us by Dinya Kader. Was he saying the same thing, that there was a third window effect?
Yes, sir. Yes, the same thing. There is a document here which I can share.
That's a good point. I must confess this had missed me in my reading. You could post it. You want to post it somewhere?
I posted a link, sir, HTTPS link.
Excellent, excellent. Okay, go on next.
Okay, sir. So yes, collectively, depending on history and findings, examination findings, this is mostly right-sided Meniere's disease. So if we see the diagnostic criteria given by Barani Society, definite Meniere's disease is defined by two or more spontaneous episodes of vertigo, each lasting for 20 minutes to 12 hours. And also there will be fluctuating oral symptoms in the affected ear. And to name it definite Meniere's disease, there should be audiometrically documented low to medium frequency SNHL in 1 year, at least in one occasion. That means before the episode or during the episode or after the episode as well. Anyone, we should document it. So if these three criteria are satisfied, then we can name it as definite. And also it should not better accounted by another vestibular diagnosis. So this is definite Meniere's disease diagnostic criteria. And if there is no audiometrically documented evidence, we can say it probable Meniere's disease as well, depending on the history. So in this, two or more episodes of vertigo or dizziness, each lasting for 20 minutes to 24 hours, along with fluctuating oral symptoms. So which is typical of in our case, she is telling the fluctuating fullness in the right ear and tinnitus and hearing difficulty as well. So yes, which is not better accounted by another vestibular diagnosis. So these are the criteria given by Barani Society.
I think number C is a kind of an outlet for people
Yes.
who are confused like me, right? So whenever you're not sure, we'll say not better accounted for, but it's a very subjective category.
Yes, sir.
Go on.
So coming into the treatment part, so we all know salt and caffeine restriction in diet, and we have to explain the patient because there will be a lot of anxiety and like this will be there. So we have to explain the patient that this increased frequency will be there in the during pregnancy and sometime after postpartum as well. After that, it may decrease also. So this thing we have to explain them. And symptomatic relief we can give with meclizine 25 mg, dimenhydrinate 25 to 50 mg, ondansetron 4 mg. These are the options available because pregnancy is a condition we don't have more options to treat the vertigo. So the safer options are these. If we can select anyone, we can give SOS, that means twice or thrice daily. We can give for the symptomatic relief. If in some cases which is very severe episode, to abort that episode, sometimes we can give diazepam 2.5 to 5 mg, IV or IM or peroral also. But this is not for prolonged usage. This is to abort the single severe episode. We can use diazepam as well. So diuretics are generally not considered in pregnancy as per safety measures. So another option we are having like intratympanic steroid injections. So there are many variations among the protocols which are followed and also the medicine which is given. So there is one review article which was reviewed 48 studies which used intratympanic steroid injections, and collectively they have mentioned like common protocols followed are maybe only once injection, or 5 injections are given alternate days, or 4 injections are given weekly once. That means in a month, four injections will be given once in a week. So generally here I know that four injections weekly once is generally being followed. So the drugs, steroids which are used, like dexamethasone is the most common one which is used. So these are the most common concentrations they are using. So generally the middle ear volume will be around 2 ml, 1 to 2 ml. So we can maximum inject up to 1 ml, not more than 1 ml we cannot inject. So it's better to take more concentration. So maybe dexamethasone we can use 10 mg per ml, but better than that 24 mg per ml if it is available, we can use that also. So that is having more superior effectiveness than 10 mg per ml. Regarding dexamethasone dosage, that is better. And methylprednisolone, there are like two preparations like 40 mg per ml and 62.5 mg per ml. So this is my like opinion that we have to take more concentration because we can't increase the quantity. And triamcinolone is 40 mg per ml. So these are the most commonly used steroids for the intratympanic injection. So generally, preparation, how we'll give the injection. So the preparation
I
will
think
be,
we'll come back to that now.
yes.
So, Rajiv, can I get your opinion here? So Anusha has said that in a case of Meniere's, she would straight away recommend uh, injection of steroids. What would your take be?
Sir, I would, it's a good option. Probably I would also think of it, but there are certain caveats. I went through the literature. Basically, methylprednisolone, dexamethasone, they all come under category C or D when given intravenously. That means there is a risk of adverse effects to the fetus. So we cannot defend in case there is a legal challenge or something later on. And also, there is no adequate evidence of intratympanic steroid advantage over other medication in Meniere's disease, as far as what I went through. Even diazepam, which is reported in many of the publications which report the treatment of Meniere's disease, is category D. So it means there is a definite risk of harm to the fetus. On the other hand, the medications which are not commonly prescribed, including beta histine, come under category B, which mean that animal studies don't show any risk of adverse effects to the fetus. So it's still an open field. I mean, it depends on your intuition and expertise also, and experience with the drugs previously, because there are no clear guidelines which is the preferred drug.
But this is now with regard to Meniere's in general or Meniere's specifically in pregnancy.
Specifically in pregnancies.
But in general, you wouldn't mind resorting to intratympanic steroids as the first go, is my question to you.
I would prefer a intravenous steroid because we would in a non-pregnant individual, because we want to reduce the systemic inflammation also in addition to the inner ear. So if you take the theory that Meniere's is because of an inflammatory disorder with deposition of inflammatory products in the endolymph, then we should in fact treat the entire body wherever the allergic complexes or inflammatory complexes are there. So probably I would think of an intravenous steroid and an oral steroid rather than an intratympanic steroid.
So I'll push the discussion a little further back. How would you consider the diagnosis of Meniere's to be clinched in your setting? Would you do an ECOG? Would you like to do a challenge test to diuretic challenge test? Would you do all, again, non-pregnant individual? Would you
Yes, sir.
like to do all this before you start treatment, or would you treat them on clinical suspicion?
I started off my career by doing, initially I used to do the dehydration test, the challenge. A couple of patients had adverse effects. They had abdominal pain and severe headache, which lasted for a day or two. So after that, I stopped doing these dehydration challenges. Then electrocochleography was not easily available. At least VNG was also not available at that time when I started practice. So then I started treating them clinically. I think most of the guidelines advocate clinical management, the diagnosis based on clinical features. VNG would be a definite plus because it's a disease which progresses, and in the early phase, we might miss out the features if we don't do a VNG, if these individuals who are having recurrent vertigo. So definitely VNG would be useful with the caloric test initially. Electrocochleography, the foil electrode is not very accurate as far as I know. So we need accurate readings. We'll have to do an invasive ECG, which I don't think many people are doing.
So this is a good time to open this question to the audience. How many of you all require a diagnosis by a clinching investigation? Anybody is open to opine? If anybody would like to give their protocol, we'd be happy to listen to it. The question again is, would you treat Meniere's on clinical, or would you like to clinch it by an investigation? Alida or Dinyar, you're welcome to give us your opinion, or anybody else who
Well,
Dinyar, go ahead.
sir, frankly speaking, we are just depending on the clinical grounds. Otherwise, we don't do any investigations. Just when attacks more than 20 minutes and there is low frequency and documented sensory loss, at that time we will treat. And sometimes, most of the time, we will give high dose of beta histine, which is actually damaging the liver. That's why I think intrathepatic injection is more and more effective. But giving intrathepatic injection, uh, you should decide when the patient actually have moderate to severe sensory loss. Otherwise, it may at the early stage you could damage the hearing. But I would like to hear from you which investigation is a gold standard for Meniere's disease.
Rajiv, take that.
Definitely a rational choice to use intratympanic steroids, but there are ways to use beta-histine without going for a very high dose. Recently, I think drugs like salicylic have been used as an adjuvant to increase the concentration of beta-histine. But again, these are things which are just coming up, so we don't have long-term evidence.
So he asked what would be a clinching diagnostic test.
For me, the clinching diagnosis will be with over a period of time having the classical fluctuating hearing and other symptoms, including vertigo.
You had to rely on an investigation. Would you say ECG is one of the clinching tests?
ECOG, I don't, unfortunately, I've not had anyone who's been able to give me good reports. So that's why I've not been able to get electrocochleography done. So I would go for VNG and serial testing.
But even a VNG may not give you very specific findings. It depends whether you'll have an irritative or.
Not in one episode, sir. Over a period of time, we'll be able to get the diagnosis.
Alida, you had something to say?
Yeah, so obviously as an audiologist, I'm going to opt for tests, but I want to tell you just what we've seen. The main thing for us is why, number one, why we do tests. We work in a multidisciplinary team with ENT and a neurologist and psychologist, etc. But so there's a full case history and all of that, but we do find that sometimes, you get your clear cut, this is Meniere's and that's it. And then I don't believe you necessarily have to do all the tests, but there are so many things that masks, each other, and your differential diagnosis just isn't clear. And what we've seen is the one thing that stands out in, I want to say 90% of our Meniere's patients, it's three things. The one thing is I do ECOG, okay, but it's not your SPAP ratio necessarily. It's when you do ray refraction and condensation opposed to just the alternating trace, and you measured the latency difference between your AP, so your peak. And we definitely see a delay there or an abnormal recording there in our patients with Meniere's disease, even when the SPAP ratio is normal. Because in a normal patient, your AP should be the same, basically the same if you do a ray refraction or condensation phase. where most people just do alternating. That's the one thing that we see. The second thing is we see very often either, I don't even want to say we often see a hyper V hit, but we often see a normal V hit with an abnormal caloric. And that to us is key. And where we're lucky is most of our patients go for an MRI, where they confirm on the MRI lymphatic eye drops or not. And it definitely correlates in those patients where we get the rarefaction condensation difference on our ECOG, a normal V hit, and an abnormal caloric. And then obviously we do, you know, your audio and that's just the basic tests. Where we do find where the VNG helps is in the differential diagnosis with vestibular migraine and Meniere's, because you get more central signs in the and oculomotor abnormalities sometimes in your vestibular migraine patients. Yeah. So, and we
That's
also do
great. No,
intratympanic
so
treatment.
thank you for that, Alida. I think you've clarified some points. I think that is very informative. But I think on the whole, uh, even your Barani criterion don't talk about investigations. Do they, Rajiv? Do they talk a lot about ECOG and stuff like that, or do they leave it at
No, sir, I think
clinical main?
the clinical diagnostic criteria are given more importance.
So, then yeah, I think that's what we're going to follow,
Yeah,
mainly clinical. We utilize
I
investigation,
yeah.
sorry.
Well, I would like to ask Alida from South Africa, what findings would you suspect in MRI of a patient with high drops? Is it easy, or does it a special technique in MRI? If she can give us a little bit clarification, what findings in MRI would be in a patient with Meniere's disease?
So,
So,
You see sac dilatation at
yes,
times, but
yes.
it's not a mandate. That's the problem with MRIs. It largely depends, like she said, Anusha said, depending on whether you, at which stage of the disease you're seeing it. You can have atrophied, or you can have, it is very unlikely you will get him during the expansile phase of the lesion. But go ahead, Alida, if you have some things to offer.
So, yeah, so
Would
we
be equivocal
usually,
is my estimate, but your call.
yeah, so obviously they do it with gadolinium or something, you know, so they do the test and then they repeat the test later on. Um, and I would say, look, some patients where we see a clear clinical, we think it's Meniere's disease and we get a normal result, especially in the beginning. So I agree with that. But I would say in about 80% of them, we actually do see on the MRI, and it's all about the way I understand it. I'm not a radiologist, but it's exactly where they do, you know, where they cut on, where they slice through to look, and then they just measure it. So it's just a case of asking them. We just ask them to always measure that for
Yeah,
us.
but the other thing is what Rajiv said, that if you have evidence of inflammation, that may pick up on the gadolinium.
so,
In
Sorry, just
contrast,
say again.
can I just briefly add? MRI has a problem, so you need to have a delayed gadolinium contrast MRI, and there are studies which show that the dilatation which is seen on MRI is non-specific. I mean, you can get it even in asymptomatic individuals. So you can't form a diagnosis purely based on the MRI unless there are gross changes.
but I was just
Yeah,
thinking
so
that
we will not use it, you know, as our diagnostic criteria, but if you put everything together, I think it does help you with the diagnosis.
yeah, I mean, I'm just coming back to that. It may pick up inflammation, which could be a justification for steroid use. That is my take on that. But good, I think that's a good discussion. Go on, Anusha.
Yes, sir. Just
So,
procedure.
so just before that, if I recall, in this patient, we push the patient through her pregnant interval without medications.
Yes, sir.
Because
Polysymptomatic
if you
really.
counsel the patient, and the only genuflection we did towards any form of treatment was we actually asked her to go on a salt restriction diet.
Yes.
So to the limit possible, we advise them to cut down on salt restriction instead of giving them diuretics, because as you pointed out, diuretics in pregnancy is a tricky medication to give.
Yes.
Rajiv, as you said, you would straight away go to steroids.
Only in the acute phase, sir. In the acute phase, definitely steroids do have a role. So I would suggest in a non-pregnant individual steroids when they come in early in the phase of the flare-up.
That is a non-pregnant individual, you would go for IV, but a pregnant person, you would still do intratympanic, I think.
Yes, sir. A pregnant person, I mean, these drugs do come under category C and D, so I don't think I would be permitted to do that. Usually, when I give drugs like these, I take the obstetrician also. I speak with them and then only I give the medication. And most of them don't want us giving all this medication.
I generally found obstetricians are kind of gung-ho about medication. They just want the child to come to pregnant state. It's the pediatricians who are more worried. Dinya, how bad is litigation in your country? Kagar bhai.
Sorry, I didn't get your question.
Uh, Dr. Rajiv was worried that if he uses aggressive medication, there are chances of litigation in the future,
Yeah.
legal cases. Is that a
Yeah,
problem in
actually,
Iraq, or
yeah,
you are
it's a
still?
very, yeah, it's a very big problem actually. Last day, my friend did a tonsillectomy and simple tonsillectomy. You know that is very easy, and the patient came out from the theater. Uh, there was no bleeding, clear. Suddenly, he developed 6 years old. He developed cardiac arrest and he passed. Yeah, he's in jail now. So what do you expect? Yeah, that's a problem actually. You know that Iraq is more like to be tribe, yes, and there are many tribes. Yeah, you do have a government, but there's a chaos. You know that what's chaos?
So,
Yeah, it's
I
a
mean,
big problem actually in our country too.
so it is a problem. Okay, go on. Anusha, please carry on.
Okay. So, like procedure, coming to procedure of intratympanic steroid injection, this can be done with endoscope or microscope. So, preparation should be done with 10%, either the 10% xylocaine spray to the tympanic membrane or cotton wool soaked in prilocaine cream, prilocaine plus lidocaine, just EMLA cream 5% placed on the tympanic membrane for 15 minutes. So we can use 25 gauge needle, mostly a spinal needle I'll use, 25 gauge spinal needle. So yeah, coming to procedure. So if this is showing that right ear, this is not the actual patient, but just to show that this is right ear of a patient. So here in the anterior-inferior quadrant, we are giving the actual injection. So generally, before that, we'll give one more bore hole just above that. That means either antero-superior or antero-inferior quadrant, just a bore hole to relieve the pressure while injecting. So just we'll give one more hole here. And then just beneath that, we can give that injection through that tympanic membrane. Most commonly 0.5 to 0.8 ml of steroid injection, which is your maybe dexamethasone or methylprednisolone solution, we can inject into the middle ear. So then afterwards, just ask the patient to lie sideways with the affected injected ear upside. So resting for 30 minutes. Uh, that's it. That is the procedure, OPD procedure.
Again, Rajiv, do you do counter hole?
Yes, sir. I always do counter hole, but one change I would do is the injected ear should not be completely up. Maybe towards the opposite side, around 15 degrees is sufficient because we want the steroid to pull in the round window niche area and not slip away from the promontory.
There are other surgeries where they do a tympanotomy and put a pledget soaked in steroids on the round window.
Yes, sir, a weak placement, but I've not seen anyone do it here in Bangalore. It
I've
is,
seen some.
there are certain wigs which are shown to be very effective, and some of the older ones are not very effective, as from what I understand. If someone has an experience, they can share.
The forum is open. We are specifically talking about intratympanic steroids. Does anybody have a different protocol? Is anybody would like to contribute on whether they have a different protocol? Because I have seen people doing it without the counter hole. Huh?
I've seen some postgraduates do that, sir. So what happens is with
I've seen faculty level do it without.
with the excessive pressure, the fluid just.
No, in fact, there are various variants. One is putting a pledget, one is putting a grommet.
Yes, that is something which I've seen some people do it, and I think in Dubai it was quite popular some time back. I'm not sure, but I've seen patients come from Dubai with a grommet and steroid eardrops.
So there are a variety of options for reaching steroids into the ear. And there were some reports of gentamicin, which was, I think, discontinued. I think steroids are gaining predominance over gentamicin. I don't know whether anybody has experience. We have a question from Manjari again on asking about the use of diuretics, dose and duration in non-pregnant. Good point. Anusha, you want to take that?
Yes, generally I'll use acetazolamide 250 mg once daily. I'll prescribe. Uh, Maybe for 6 weeks I'll prescribe, sir, first.
Yeah, but
Depending on the response.
I think, like Rajiv said, when you start using this, the patients don't take too kindly to it. I don't know whether you agree. Have you been able to make people take a full course of acetaminophen?
I used to give hydrochlorothiazide, sir, but I used to prefer beta-histine and then hydrochlorothiazide as a second drug when that was not sufficient, and they're quite fine with it. The one issue I had with a patient, incidentally, is that he went to a physician and he said, "This is a drug for hypertension. Who has given you?" And he made him stop the
But
diuretics.
I think the literature says acetazolamide is a more accepted drug than hydrochlorothiazide. Am I right? I don't know. You could take me on that.
No, sir. I think hydrochlorothiazide is also an accepted drug. I think in the US they use more of hydrochlorothiazide. I'm not sure now. I read about it maybe 5 to 6 years ago.
Fair enough. You have anything else to share?
That's it, sir. Sir, just to, I have it
One,
down here, like,
one thing we can consider is Miniate device. Miniate device, you have not put it up. It's
yes.
actually available, Miniate device. It can be considered in pregnant individuals, I suppose, because it's a non-invasive intervention. And so that is one of the possible things which we can think.
Could you tell us something about the Miniate device?
Basically, we have to put a grommet, and then the device is used by increasing the pressure in the external aortic canal. So the theory is that it compresses the foot plate and temporarily increases the pressure and increases the endolymphatic drainage, endolymphatic pressure, and improves the drainage by means of transient pressure increases. I haven't used it myself, but it was not available till a few years ago. But I think we can consider using it in a few individuals who drugs don't work.
So, a question in general to people who anybody has experience with Miniate device. Alida, have you seen that being used? If you're still here.
Yeah, I'm still here. So we have in South Africa been discouraged to use it because there were some initially some studies done, and it didn't, there was more like a placebo effect. So there wasn't any evidence-based practice to strongly suggest, and I think in the American Otolaryngology Society, in their guidelines, they also discourage people from using it. But I think, when you get to a point maybe where nothing else helps, I don't know. I mean, I know there are some studies with individual cases that shows that it did help, but we're not using it in South Africa.
There's a follow-up question which I would like to pose. See, there was a time, and I can honestly confess I was part of this thing where we used to do surgery for endolymphatic eye drops. We would always start with uncapping the posterior fossa and reducing the pressure. The few aggressive ones among us would incise this thing and put in a grommet-like device or a silastic roll. There were some hyper aggressive who would make shunts between that and the thing, and that used to be done. It somehow seems to have disappeared from the lexicon. I think apart from one surgeon in Andhra Pradesh who is still aggressively operating, I don't see many people resorting to surgeries. What do you think, Rajiv?
I think in many of the conferences, they always have this panel on surgery for many disease. And I think Professor Kirtane is one of the few people who has experience with cases. I had another couple of people saying that they are doing it, sir, but I'm not sure. I personally don't have any experience with it.
Because there are a lot of people now who do keyhole surgery where they cut the vestibular nerve. That's making a comeback.
Yes, sir. So there are some new procedures. I'm not very familiar with them.
No, so I think of all the procedures now, the go-to procedure is to make a keyhole and just cut the vestibular nerve. So you do a selective vestibular neurectomy. And they claim that, the claim and the reason, the justification they give is it preserves the hearing. It removes the vertigo and preserves the hearing because you're doing selective vestibular neurectomy. I don't have experience. I have honestly done sac decompressions, but go on. Dinya, you want to say something?
Yeah, well, if there are no any papers that could document this, I think these are old procedures that are not done nowadays. Even
No,
giving
vestibular
uh,
neurectomy is making a comeback. That's my point.
comeback
Yeah, with
without
selective.
affecting hearing.
Yeah, because you're doing only the vestibular nerve. You're not touching the cochlear nerve, and it is a keyhole
Which one?
surgery. So that's making a comeback. Again,
Inferior.
I'm not justifying it. I'm just saying I'm hearing increasing reports about that.
I
So
think nowadays just approaches to giving intratympanic injection and even giving like our friend said, Rajiv, uh, diuretics is not nowadays used. Just beta-histine high dose with food restriction and tapering the dose of beta-histine. I think nowadays we are using just this, maybe 48 milligrams per day or 96 milligrams per day, and tapering the dose slowly until the symptoms will resolve.
yeah, but I think the very fact that we are still discussing Menias so many years after Prosper Menias is kind of a reiteration of the fact that Menias will be around for a long time. A lot of medications will be made. A lot of people will earn their daily bread through it. So I think we should all raise a toast when we go back to Menias so that the disease is going to keep hearth and home healthy. Uh, what
Salt restriction, I think nowadays is not, again, it's not something which regard as to be affecting the life of patients with Meniere's disease, isn't it?
Yeah, I mean, I was just saying that in this
Salt
particular
restriction.
patient, because you didn't want to give any medications and she was not keen on getting that, what else can you offer? So we pushed her towards that. And I think she negotiated the pregnancy.
Yeah.
She's now a candidate for steroid injection because she is delivered, touch wood, without any problems. But the amount of counseling you have to do for these patients is tremendous, because it's very distressing for them. So I think the problem about vertigo is that unless you get it, you don't realize how distressing it is. As long as we are fortunate not to get it, I think uh, one of our doctors in the neurotology space said that he was forced to start diagnosis and treatment of vertigo because his wife had vertigo. So that was an impetus for him to go deep into the subject, and he's got pretty good at it. Um, so I think at this stage, we leave this beautifully unresolved unless somebody has something else to offer. Rajiv, would you like to uh, give any closing comments?
Meniere's disease is a difficult problem to address, and I think the diagnosis, if it's straightforward, then treatment is easier. In early stages, it becomes the diagnosis itself is difficult. The treatment is confusing because of so many things which we have to take into consideration. When the patient has additional conditions like pregnancy, the treatment becomes more difficult. And it always has to be a conversation between the physician, the patient, and the obstetrician in this condition before we start on any course of treatment.
Is it? I have an observation that many cases of Meniere's, we are actually waiting for a burnout, because whatever you do is not actually addressing the progress of the disease.
Most of my patients, sir, I notice that they have frequent episodes for a few years, maybe 4 or 5 years, that they go into a sort of a remission. And then afterwards, they might have another flare up. But once they go into that remission phase, most of them don't come back unless they have a flare up.
I mean, maybe I can claim the benefit of age, not that I've been a better doctor, but I've followed up more cases. And I find that the patient who comes and says, "Look, I'm free from vertigo," is invariably deaf in 1 year. So the tendency for burnout to be the last stage of the disease is getting more and more. This is my observation. I don't know. I don't have a study to back this up.
Definitely. So maybe I haven't had the follow-up which you have had. So most of my patient follow-ups may be between
Because
5 to 8 years.
I came into a stage where, I used to dread the patient coming back, because I've shot all my arrows at him. And then he said, "No, doctor, I'm very fine and I'm very happy." And then while going, I very hesitantly ask him, how are you feeling? How's your hearing? And they all say, "I can't hear in that ear, but I have no vertigo anymore." So I don't know. This is so I must thank you, Anusha. I must thank you, Rajiv, and I must thank Dr. Kader. I must thank Alida from
Thanks.
South Africa with the lovely voice and the lovely Australian accent, and all the others who contributed for the discussion. And I must stick to time. I have been warned that I should not exceed beyond 8:30, so I think we've reached our time limit. So thank you very much. I invite you for the next month, last Friday of the month, calendar event. We'll find some more interesting cases to share. And if anybody in the audience has a case which they would like to share, please reach out to us. We'll be happy to allow you to discuss it. Dr. Kader, Alida,
Thanks a lot.
anybody else who's listening, if you have a case, please share. Right? Thank you very much.
Thanks a lot.
Thank you for
Thank
everyone.
you.
Thank you.